Welcome to the deep dive. Today, we're tackling a really important and, let's face it, often debated topic: using adjunctive hyperbaric oxygen therapy, or HBO2, to help heal diabetic foot ulcers.
Exactly. And we've really pulled together quite a range of research here, everything from the early observations, some historical context, right up to the latest clinical practice guidelines.
Hmm.
The idea is to really get to the core of, when and why HPO2 might be a helpful addition to standard care.
And these ulcers are no joke, right? I mean, it's usually not just one problem, it's often a complex mix. Poor blood flow, maybe nerve damage, infection thrown in.
Yeah.
That makes them so difficult to treat sometimes.
That's right. And we absolutely have to stress the basics first. Thorough vascular checks, making sure pressure is taken off the wound, offloading, controlling any infection, managing blood sugar, regular cleaning, good local wound care. That's the essential foundation.
Right. Absolutely essential.
And it's critical, really, for everyone listening to understand that HBO2 isn't meant to replace any of that standard treatment. Our mission today, if you like, is to figure out when HBO2 could give an extra boost.
Okay, so for which specific patients might it make a real difference? And maybe why the evidence sometimes seems, well, a bit conflicting.
Precisely. We need to unpack why there's debate and try to find some clarity.
Okay, let's dive into the science first. How is HBO2 actually supposed to work? What's the underlying mechanism for helping a diabetic foot ulcer heal?
Okay, so the fundamental goal, the basic idea behind HBO2 is to counteract that lack of oxygen, the hypoxia, and the impaired healing process we so often see in these ulcers.
Right.
So when a patient breathes 100% oxygen inside a chamber where the pressure is significantly higher than normal air pressure, it creates a much steeper oxygen gradient. Think of it like force-feeding oxygen into the tissues around the wound.
Okay, hypersaturating it, basically. And what does all this extra oxygen actually do at the local level, right there in the ulcer bed?
Well, it sets off a kind of beneficial chain reaction.
Yeah.
We see a surge in the levels of really key growth factors, things like VEGF, FGF, TGF-beta, nitric oxide, PDGF, names you might have heard.
Uh-huh. The building blocks for repair?
Exactly. They're all vital for encouraging the growth of new blood vessels, angiogenesis, and repairing damaged tissue. And it also helps attract the essential wound healing cells, like fibroblasts and neutrophils, to the area. So it's like providing both the raw materials and the workforce needed for repair right where they're needed most.
That paints a really clear picture, a local boost. But you mentioned it has broader effects too, systemic effects.
Yes, that's also quite interesting. Systemically, HBO2 seems to stimulate the movement of what are called endothelial progenitor stem cells, or EPCs, out of bone marrow and into the bloodstream.
Stem cells, okay. How does it do that?
It primarily achieves this through an enzyme called endothelial nitric oxide synthase, or EDAR. Now, what's really fascinating here is that this process boosts nitric oxide levels without relying on the typical signaling pathways which are often, frankly, dysfunctional in people with diabetes. So it's essentially finding a biological workaround.
Ah, a clever way to bypass a common roadblock in diabetes. And what happens with these mobilized EPCs? Where do they go?
Well, they travel through the bloodstream to the site of the injury, the ulcer, and there they contribute to the formation of new blood vessels. That's the neovascular genesis we mentioned. And they also help in producing collagen.
Collagen, the structural protein, crucial for closing things up.
Absolutely crucial. So clinically, what we often observe or hope to observe is enhanced formation of granulation tissue, that healthy pink bumpy tissue that starts filling the wound, and just an overall improvement in the wound bed, making it more receptive to healing. If you look at diagrams, like the figure 1 often cited in papers, it shows this cascade quite nicely: growth factors, cell recruitment, the whole process.
Okay, so we get the why it could work. The biological rationale seems pretty solid. Now, let's look back a bit. How did this idea first gain traction? What were some of the initial observations that got people interested in HBO2 for DFUs?
Right. The history is quite informative. One of the earliest reports dates back to 1979. It was a retrospective look by Hart and Strauss. They looked at about 35 patients with various persistent skin ulcers. Now, among the 11 who had diabetic foot ulcers, they noted improvement or even complete healing in a decent number.
Promising early signal.
Promising, yes. But we have to remember, reporting standards back then weren't what they are today. The report lacked a lot of specific details: how severe the ulcers really were, the exact HBO2 protocol used, that sort of thing. So encouraging, but not definitive.
Okay. What came next?
Well, fast forward to 1987, Davis and colleagues published a case series focused specifically on diabetic foot ulcers treated with HBO2. A larger group this time, 168 patients, and they reported a 70% healing rate.
70% sounds pretty good.
It does sound promising. But again, a key limitation. There was no control group, no direct comparison to patients who didn't get HbO2. So we can't definitively say the HbO2 caused the healing.
Right, correlation isn't causation.
Exactly. They did make an interesting observation, though. They noted that HbO2 seemed less effective in older patients who had significant blockages in their major arteries, above or at the ankle, large vessel disease.
Okay.
And interestingly, they didn't really mention whether these patients were using specific methods to offload pressure from their ulcers, which, as we know now, is absolutely critical.
Yeah, the focus on all those standard care elements wasn't quite as systematic back then, perhaps. So these early studies hinted at a benefit, but definitely lacked that rigorous comparison. Now, you mentioned some Italian researchers really moved the needle.
Oh, yes. The work coming out of Italy, particularly from Baroni, Oriani, and Faglia, was really pivotal in the late 80s and early 90s. Baroni and his team published a prospective study in 1987 that was a major step forward.
Perspective, so they planned it in advance.
All right, they studied 28 hospitalized patients, all with severe diabetic foot ulcers. Most had gangrene, what we call Wagner grade 4, and some had deep ulcers, maybe Wagner 2 or 3. They compared 18 patients who got HbO2 with 10 who didn't.
And the results?
Quite striking, actually. The HbO2 group showed significantly higher rates of complete healing and, crucially, much lower rates of major amputation compared to the control group. This really suggested a substantial benefit, particularly in these very severe cases.
Wow, okay. That's a big difference. What kind of HbO2 protocol were they using?
That's pretty intensive. They used 90-minute sessions at quite high pressure, 2.5 to 2.8 atmospheres absolute, or ATA. They actually started higher, thinking about antibacterial effects, then dropped it slightly for tissue repair focus. On average, the patients got around 34 treatments.
And did they see other benefits?
They noted faster healing times and a trend toward shorter hospital stays in the HbO2 group, although that particular finding didn't quite reach statistical significance.
And what about the other aspects of care, the standard stuff?
For the time, they were quite thorough. They emphasized daily debridement, removing dead tissue, used wound cultures to guide antibiotic choices, and carefully managed blood sugar with frequent checks and insulin. They also used ultrasound to check for major blood vessel disease, though they didn't report pursuing revascularization based on those findings specifically.
And offloading.
They didn't explicitly detail offloading strategies in the paper, but given the extended hospital stays, we can probably infer some level of pressure relief was happening, just maybe not documented in the way we would today.
Okay, so a strong early indication, especially for those severe ulcers. And then Oriani's group built on this.
Exactly. In 1990, Oriani and colleagues published a retrospective review, looked at 80 patients, again with advanced ulcers and gangrene. They described a similar intensive approach. Long hospital stays, strict glucose control, aggressive daily debridement, culture-guided antibiotics.
And the HbO2.
The HbO2 group, in their review, actually received even more treatments on average, something like 72 sessions. And their findings were, frankly, even more impressive than Baroni's. They reported a 95% healing rate and only a 5% major amputation rate in the HbO2 group.
95% healing, that's remarkable.
It is. Compare that to much lower healing and significantly higher amputation rates in their control group. These results really bolstered the case that HbO2 could be a powerful tool for limb salvage in these really challenging situations.
Those are incredible numbers. It certainly points towards a significant positive impact, and this Italian group, they continued this work.
They did. In 1992, they summarized their experience over a decade, covering 172 patients by then. They really emphasized starting HbO2 earlier in the process, using it as part of a coordinated strategy, to help define the extent of tissue damage, make surgical debridement more effective, and promote repair afterwards.
How do they define success? Their
Their definition was either complete wound healing or, importantly, avoiding amputation of the leg or thigh, so limb salvage. They reported an 86% success rate in patients who completed at least 12 HbO2 sessions.
And what principles did they highlight from that decade of experience?
They stress things that are still absolutely key today. Early intervention, using a multidisciplinary team, getting podiatrists, vascular surgeons, infectious disease docs, everyone involved, and regularly reassessing how the patient is actually responding. They even recommended stopping HbO2 if there weren't clear signs of improvement, either clinically or based on oxygen level testing.
That sounds like a really sensible, structured approach. So these early Italian studies, they really laid a strong foundation, suggesting a key role for HbO2 in saving limbs, especially with severe DFUs. Now, what happened when researchers started doing more rigorous studies like randomized controlled trials or RCTs? Did they confirm these really positive findings?
Well, that's where the picture starts to get, let's say, a bit more complex, a bit more nuanced. The first RCT, published in 1992 by Doctor and colleagues, was, well, it was somewhat unusual.
How so?
They used a very short course of HbO2, only 4 sessions, but at a very high pressure, 3 ATA over just 2 weeks. A very atypical protocol compared to what Baroni or Oriani were doing, or what's common now.
Okay, short and intense. What did they find?
Despite the weird protocol, they actually reported lower amputation rates and fewer wound infections in the HbO2 group. But because the treatment was so different, it's really hard to generalize those findings to most clinical situations.
Right. Limited applicability.
Exactly.
Yeah.
But it did raise an interesting question. Could even very short courses of HbO2 have some benefit, maybe in specific situations, like right after surgery perhaps? An intriguing thought, but not definitive.
Okay. And then came Faglia's 1996 RCT. That one seems to be cited a lot, a really significant study in this field.
It was, yes, hugely influential. Faglia and his colleagues conducted a non-blinded RCT. They enrolled 68 hospitalized patients. These patients had either Wagner grade 3 or 4 ulcers, or they had large infected Wagner grade 2 ulcers that just weren't getting better without patient care.
Okay. And what was unique about their approach?
A key thing, and different from many other studies at the time, was that they specifically included patients with significant peripheral artery disease, PAD, poor circulation. In fact, they were very proactive about it. Anyone showing signs of poor circulation underwent angiography to map out their arteries.
And if they found blockages?
If significant blockages, stenosis, or occlusion were found, they were treated with angioplasty or bypass surgery before starting the HbO2. This emphasis on restoring blood flow first was a really crucial part of their study design.
That makes a lot of sense. Get the blood flowing before you try to supercharge the oxygen. So what were their main findings?
They found a significant reduction in the rate of major amputations in the group that received HbO2. They also documented an increase in the actual oxygen levels measured in the tissues of the feet in the HbO2 group.
And was the benefit seen across all ulcer types?
The benefit, particularly the reduction in amputations, seen most pronounced in the patients with the most severe ulcers, those classified as Wagner grade 4.
And this study had a big impact.
Huge impact. This study was a major driver behind the decision by CMS, the Centers for Medicare and Medicaid Services in the U.S., to approve Medicare coverage for HbO2 for treating diabetic foot ulcers. The positive outcomes, especially fewer amputations in a well-defined group who also got aggressive vascular care, were very compelling evidence.
Okay, so it directly influenced healthcare policy. That's significant. But you mentioned earlier there was a bit of a mismatch between the study population and the actual CMS guidelines that resulted.
Yes, and this is a really important nuance to grasp. Faglia's study, remember, used HbO2 right away for all their Wagner grade 3 and 4 patients, and only waited the 30 days for the resistant Wagner grade 2s. But the CMS guidelines that came out restricted coverage to patients with Wagner grade 3 or higher ulcers that had already failed to show improvement after at least 30 days of comprehensive standard wound care.
So the guidelines require a documented failure of standard care first, even for the severe grade 3 plus ulcers, whereas Faglia treated those immediately.
Exactly. So the patient population covered by the CMS rule doesn't perfectly mirror the population where Faglia demonstrated the most significant benefit. And the CMS criteria also heavily rely on the Wagner classification system itself for eligibility, even though, some argue other wound classification systems might actually be better predictors of healing.
That really highlights the challenge, doesn't it? Taking findings from a controlled research setting and translating them into broad clinical practice rules. So after these early trials, it sounds like the focus shifted. People started trying to really pinpoint which specific patients were most likely to benefit from HbO2, zeroing in on predictors.
Precisely. Researchers started looking for specific characteristics, or maybe measurements, that could predict whether a patient's ulcer would respond well to HbO2. Back in 1991, Wattel et al. Published a case series exploring this.
And what did they find?
They found that the level of oxygen measured in the wound tissue, while the patient was actually inside the hyperbaric chamber, the in-chamber TCPO2, seemed to be linked to whether the ulcer eventually healed. Patients whose ulcers healed had significantly higher levels of oxygen getting into the tissue under pressure.
Interesting. So it's not just about the baseline oxygen level, but how well the tissue responds to the hyperbaric environment, how much oxygen it can actually take up.
That seems to be the key insight, yes. Faglia's group also kept digging into this. In a 1998 retrospective study, they looked back at their patients to identify factors associated with a higher risk of needing a major amputation.
And what factors stood out?
Things like having had a previous amputation, having a more severe ulcer, a higher Wagner grade, a history of stroke, and, importantly, low measurements of both the ankle brachial index, or ABI, which measures blood flow, and that transcutaneous oxygen pressure, the TCPO2.
Okay. And what about HbO2 itself in that analysis?
Interestingly, they found that receiving HbO2 therapy was an independent factor that seemed to protect against needing a major amputation, even after accounting for those other risk factors.
So it seemed to offer a benefit even in their retrospective look.
Yes. And they also noted something else important. The overall rates of amputation in their center had actually decreased over time. They attributed this, at least partly, to the development of a dedicated multidisciplinary foot care team, which just reinforces that idea. We keep coming back to the comprehensive approach.
Right, the whole package matters. HbO2 works best as part of that bigger picture. Now, what about those really tough cases? Patients with such severe circulation problems that they aren't even candidates for surgery to improve blood flow. Is there any hope there?
Well, a small study by Zamboni and colleagues in 1997 offered a little bit of hope in that very challenging area. They looked at a small group, some of whom had critical limb ischemia, where revascularization just wasn't an option.
Yeah.
The group that received HbO2, even though they actually started with lower baseline oxygen levels in their tissues, showed a greater reduction in ulcer size and a higher rate of healing compared to the controls. Now, because the study was small, these differences didn't quite reach statistical significance.
But it hinted at a potential benefit.
It suggested that maybe, just maybe, even when you can't fix the underlying blood flow problem surgically, HbO2 might still have a role to play in kickstarting the healing process.
Interesting. A potential niche even in very advanced disease. And then Fife and colleagues, they really dove deep into using these TCPO2 measurements to predict response, didn't they?
They really did. Their two large case series, published in 2002 and 2007, heavily emphasized the value of TCPO2 measurements for predicting outcomes with HbO2. They crunched a lot of numbers.
What were their key findings on TCPO2?
They found a pretty clear pattern. Patients who had very low oxygen levels in their wound tissue, even while inside the chamber specifically, less than 100 millimeters of mercury, had a very low chance of their ulcers healing with HbO2 alone.
Okay, a poor prognostic sign.
Right. Conversely, those who achieved levels above 200 millimilli He while under pressure in the chamber showed much, much better healing rates. They even identified a kind of double whammy predictor of failure, having low oxygen levels measured in normal air and low levels achieved under hyperbaric pressure.
So consistently poor oxygenation predicts failure. Did they identify other factors?
Yes, they also highlighted other things that could negatively impact healing, like kidney failure, ongoing smoking, not getting enough HbO2 treatments, or having lots of interruptions in the treatment schedule. Consistency seemed important.
So TCPO2 emerges as a potentially really valuable tool for selection. And did other research back this up? Strauss, you mentioned?
Absolutely. Strauss's work, also around 2002, confirmed Fife's findings. He found that achieving that in-chamber TCPO2 measurement above 200 millimilli Hg was a strong predictor of healing, pretty much regardless of what the oxygen levels were when measured in just normal room air.
So the response under pressure is key.
It seems to be. In fact, looking back at the combined data from Fife and Strauss, it suggests that nearly 90% of ulcers that hit that 200 millimilli Hg mark under pressure eventually wanted to heal. That's a pretty strong correlation, giving clinicians a more objective benchmark to assess the potential for success.
That's a significant finding. A more objective criterion is always helpful. Now, what about the less severe ulcers? We've talked a lot about grade 3 and 4. What about Wagner grade 1 or 2? Is there evidence for using HbO2 in those cases?
That's a good question. Kalani and colleagues looked specifically at this in their 2002 study. They focused on chronic ulcers, ones that had been around for more than 2 months that were Wagner grade 1 or 2, but showed signs of hypoxia, low oxygen.
And what did they find in that group?
They found a trend towards better healing and lower amputation rates in the group that received HbO2 when they followed them up 3 years later. And again, echoing the other studies, those patients whose ulcers healed tended to have higher oxygen levels measured in their tissues while inside the hyperbaric chamber.
Okay, so a suggestion of benefit maybe for hypoxic but less deep ulcers.
Possibly. But it's important to add a caveat. The way patients were assigned to the treatment groups in that study wasn't fully randomized, which means there could be some bias influencing the results. So suggestive, but maybe not definitive.
Got it. Handle with care. And then there was a study by Kaya et al. In 2008 that looked at a broader range, Wagner 2 through 5.
They did. They reported a relatively low rate of major amputation in the patients they treated with HbO2 across that range. However, there are some, let's say, methodological points to consider with their study.
Such as?
Well, for one, they didn't collect data on tissue oxygen levels, the TCPO2 measurements. That makes it harder to interpret their findings in the context of wound hypoxia, which seems so critical based on the other research.
Right, missing a potentially key piece of data.
And also, looking back at the photographic evidence available from their study, there's been some discussion, some uncertainty, about whether all the ulcers they classified as Wagner grade 5, the most severe category involving the whole foot, truly met those criteria. So maybe some issues with classification consistency.
Okay, so while it showed some positive outcomes on the surface, the lack of oxygen data and potential classification issues make it a bit harder to draw really firm conclusions from that one. So, we've covered a lot of the observational studies and earlier RCTs. Many showed positive signals, especially, it seems, for the more severe ischemic hypoxic ulcers. Now, what about the more recent randomized controlled trials? Have things become clearer with more recent, maybe more rigorously designed studies?
Well, there's definitely been a noticeable trend in the more recent RCTs, say from the early 2000s onwards. Many of them incorporated a preliminary screening or run-in period, often lasting at least 4 weeks, before patients were actually randomized into the study.
A run-in period, what's the significance of that?
It likely means they were screening out the more severe acute ulcers, the ones needing immediate hospitalization or intervention. Instead, they tended to focus on patients with more stable chronic ulcers, the kind often managed in outpatient clinics.
Ah, so the type of ulcer being studied might have shifted compared to those earlier studies like Faglia's that included acutely ill hospitalized patients.
Exactly. And that difference in the patient population could certainly influence the outcomes you observe. Studying a less acute group might lead to different conclusions about maybe the immediate impact or the magnitude of benefit from HbO2.
That makes sense. So let's look at some of those. Abidia et al.'s 2003 double-blind RCT. They looked at Wagner grade 1 and 2 ulcers in patients with PAD.
Yes, and theirs is a good example of this potential delayed effect. They didn't find a significant difference in healing rates between the HbO2 group and the placebo group at the end of the 6-week treatment period.
Okay, so initially, no difference.
But crucially, when they followed the patients for a full year, the group that had received HbO2 showed significantly better healing rates. It suggests a benefit that might take longer to become fully apparent, a kind of delayed but persistent effect.
Interesting. A long-term view might be needed. What about the study by Kessler and colleagues also in 2003?
They looked at slightly more severe ulcers, Wagner grade 1 to 3, but ones that had been present for at least 3 months, so chronic. They did see a faster reduction in wound size in the HbO2 group during the first 2 weeks of treatment.
Okay, an early positive sign.
Yes, but they didn't find any significant difference in the overall healing rates at the end of the 4-week treatment period. It's also worth noting they specifically excluded patients who had very low baseline TCPO2 levels, which, based on what we discussed, might have excluded patients most likely to show a dramatic response.
Right, potentially excluding the responders.
Possibly. And their follow-up was relatively short, just the 4 weeks of treatment, so we don't know about longer-term outcomes like in Abidia's study.
Short follow-up is definitely a limitation in wound healing studies. Okay, then there's the 2008 study by Duzgun et al. That one reported some pretty striking results, didn't it? Higher healing, lower amputations.
They did, yes. They reported higher rates of healing without needing surgery and lower rates of amputation in the HbO2 group. They studied ulcers, classified as Wagner grade 2 to 4, using a slightly modified scale. However, their study also had some limitations we need to consider.
Like what?
Well, for starters, the surgeon who made the decisions about whether or not to amputate wasn't blinded. They knew which patients were getting HbO2. That introduces a potential for bias, conscious or unconscious.
Right, the decision maker wasn't objective.
And also, their definition of healing was a bit unusual. They defined it as spontaneous healing without requiring any surgical intervention. If you just look at the straightforward number of ulcers that completely healed in both groups, a more typical definition, the calculation suggests a healing rate may be around 74% in the HbO2 group versus about 18% in the control group.
That's still a big difference.
It is still a significant difference, yes. But the non-standard definition of the primary outcome does raise some questions about exactly how we should interpret their main reported results. Consistency in outcomes is key for comparison.
Absolutely. Having clear standard definitions is so important. Now, the 2010 trial by Lundahl and colleagues, that one's often highlighted as being particularly rigorous, isn't it? Influential.
Yes, it's generally considered a very well-designed study. It was double-blind, placebo-controlled using sham treatments, and looked at chronic Wagner grade 2 to 4 ulcers. They included patients who either had adequate blood flow or had PAD that couldn't be fixed surgically.
So a relevant patient group, what did they find?
They found significantly higher rates of complete healing at 1 year in the group that received genuine HbO2 compared to the sham group. And this benefit was particularly noticeable in patients who received more than 35 HbO2 treatments.
Interesting about the number of treatments. Any other key findings?
Well, interestingly, they did observe a slight non-significant increase in major amputations in the HbO2 group, which warrants some thought. But their analysis of different patient subgroups reinforced what we've seen elsewhere. Patients who started with better oxygen levels in their tissues, a higher baseline TCPO2, were more likely to heal with HbO2.
Confirming that TCPO2 link again?
Yes. They even suggested, based on their data, that HbO2 might be most beneficial for patients with a baseline TCPO2 above 25 millimillis G. So overall, this study provides pretty strong support for using HbO2 in this specific group. Patients with chronic, moderately severe DFUs, especially if their baseline oxygenation isn't severely compromised.
Okay, Lundahl's study sounds like compelling evidence for that population. What about the trial by Ma et al. In 2013?
They studied hospitalized patients who had Wagner grade 1 to 3 ulcers, again chronic ones, present for more than 3 months. They found that the ulcers in the HbO2 group showed a greater reduction in size after 14 days of treatment.
So faster initial progress.
Yes, but they didn't report any longer-term data, like complete healing rates or amputation rates. So we only have that short-term snapshot. Importantly, though, in their study, both the HbO2 group and the control group received really strict protocols for offloading pressure and for managing blood sugar levels.
Emphasizing that good standard care baseline again.
Exactly. It highlights again that HbO2 is being tested as an addition to, not a replacement for, really good fundamental wound care.
Right. Okay, we've discussed quite a few studies now that have shown positive results, or at least positive signals. But to get a truly balanced picture, it's crucial we also look at the studies that didn't find a benefit or even suggested potential harm. These are important too.
Yes, absolutely. And it's important to examine these negative studies just as critically as the positive ones. One study that certainly generated a lot of discussion and, frankly, controversy was the large observational cohort study by Margolis and colleagues, published in 2013.
Right, I remember that one. It reported worse outcomes with HbO2, didn't it? Lower healing, higher amputations.
That's correct. It analyzed a large database of patients and reported that those who received HbO2 actually had lower healing rates and higher amputation rates compared to those who didn't. As you can imagine, this led to considerable debate within the wound care and hyperbaric medicine communities.
I bet. So what were some of the main criticisms or concerns raised about the Margolis study's methodology or interpretation?
Several points were raised. Firstly, while it was sometimes described as prospective, it was fundamentally a retrospective analysis of existing patient data collected for other purposes, which has inherent limitations. Secondly, and perhaps most critically, it appeared that the patients who ended up receiving HbO2 in this real-world dataset were generally sicker, with more severe, complex ulcers to begin with.
So not comparing like with like.
Potentially not. These patients might have been less likely to heal and more likely to need an amputation, regardless of whether they received HbO2 or not. Also, in that database, patients typically had to have failed at least 4 weeks of standard wound care before they were even considered for HbO2. This suggests the HbO2 group might have been enriched with ulcers that were inherently more resistant to healing from the start.
So a selection bias issue.
A significant potential for selection bias, yes. Now, the researchers used sophisticated statistical methods, propensity score matching, to try and account for these baseline differences between the groups. But these methods can only adjust for factors that were actually measured and recorded accurately in the database. there might have been other important differences between the groups that couldn't be accounted for.
Right, you can only adjust for the variables you have data on. Was there anything else?
Another point raised was that a significant proportion of patients with less severe Wagner grade 2 ulcers received HBO2 in that study cohort. At the time, this wasn't really in line with the prevailing guidelines, which focused more on grade 3 and higher. This raised questions about whether HBO2 was perhaps being used inappropriately or maybe overused in some cases within that healthcare system.
So maybe not targeted effectively.
That was a concern. Margolis himself acknowledged this distinction. He argued his study reflected the real-world clinical effectiveness of HBO2 as it was actually being used in practice at that time and place, which might be different from the efficacy demonstrated in tightly controlled RCTs like Faglia's or Lundell's. Some also speculated, though it's hard to prove, that financial incentives within that specific healthcare system might have inadvertently encouraged overuse of HBO2, potentially diluting any real benefit by including patients less likely to respond.
That really underscores the complexity of studying treatments in the real world versus in a controlled trial setting. Effectiveness versus efficacy. Okay, what about the 2016 RCT by Fedorko et al.? That one also had a largely negative outcome, right?
Yes, the Fedorko trial, often called the HODFU study, conducted in Canada, it was a double-blind RCT looking at patients with Wagner grade 2 to 4 ulcers. They specifically excluded patients who were considered good candidates for revascularization procedures.
And their main finding.
Their primary finding was that there was no reduction in the indications for amputation in the group that received HBO2 compared to the sham placebo group.
Indications for amputation, that sounds like an unusual endpoint.
It was, and it's been a point of criticism. The determination of whether there was an indication for amputation was based on a retrospective review of patient charts and photographs by blinded reviewers rather than, say, predefined clinical criteria applied prospectively or actual amputation rates. They also didn't report the baseline rate, what percentage in each group already met these indications before the treatment started.
That does seem problematic for interpretation. Were there other concerns?
Yes, there were subsequent discussions, critiques, and even some allegations raised regarding aspects of the study's protocol. The patient population actually enrolled, which ended up having lower Wagner grades than initially planned. And the way the results were reported and interpreted, it became quite contentious.
So another complex study with contested findings. How did policymakers react to that one? You mentioned Ontario earlier.
Right. Despite the negative primary outcome of the Fedorko study, the Health Technology Assessment Agency in Ontario reviewed it alongside other evidence. Their ultimate recommendation was actually to continue funding HBO2 for diabetic foot ulcers in the province, but they restricted its funded use specifically to those with more severe ulcers, Wagner grade 3 or higher.
Interesting. So even with that negative RCT, they still saw value in specific cases.
It suggests that looking at the totality of the evidence, they still felt there was a role for HBO2, particularly in the more severe cases, aligning somewhat with the CMS policy in the U.S. It shows that one study, even an RCT, doesn't necessarily overturn the entire body of evidence, especially if there are questions about its methodology or applicability.
That makes sense. You have to weigh everything together. So with this somewhat mixed picture from individual studies, some positive, some negative, lots with nuances and caveats, it's no wonder clinicians often turn to systematic reviews and clinical practice guidelines to try and make sense of it all.
Absolutely. And there have been a lot of systematic reviews and meta-analyses published on HBO2 for DFUs. It's a popular topic for review.
What's the general trend in those reviews?
Well, the earlier reviews often concluded, quite rightly, that there was a real lack of high-quality research, particularly large, well-conducted RCTs. However, as more RCTs like Lundell's became available, the more recent reviews have tended to be, on balance, more positive.
More positive in what way?
Some have concluded that HBO2 likely leads to a reduction in major amputations. Others suggest it improves the rates of ulcer healing, and some find evidence for both. But it's not unanimous. For instance, a major Canadian review, the PATH review, reached more cautious conclusions, highlighting the remaining uncertainties.
And why the variation even among reviews?
A major challenge, which the reviews always point out, is the significant variation, the heterogeneity between the studies being combined. Different patient populations, different HBO2 protocols, different ways of measuring outcomes. It makes it really difficult to pool the data cleanly and draw firm, universal conclusions. It's like comparing apples and oranges sometimes.
Yeah, that heterogeneity is always a complicating factor in meta-analysis, so the reviews are somewhat positive but cautious. What about the clinical practice guidelines put out by major medical organizations? Do they offer a consistent message?
Not entirely, unfortunately. There's definitely some variation there, too, reflecting the complexity of the evidence. For example, back in 2012, the Infectious Disease Society of America, IDSA, guidelines suggested that HbO2 might be a helpful adjunct to prevent amputations in some cases.
Okay, a cautious maybe.
Then you have NICE, the National Institute for Health and Care Excellence in the UK. In 2015, their guideline recommended against the routine use of HbO2 for DFUs outside of clinical trials, citing cost-effectiveness concerns and insufficient evidence for widespread use.
So a much more restrictive stance there.
Right. Then the International Working Group on the Diabetic Foot, IWGDF, in their 2016 guidance, took a middle ground. They suggested considering HbO2 as a treatment option, but strongly emphasized the need for more rigorous research to really confirm its cost-effectiveness and, crucially, to better identify the specific patient populations who stand to benefit the most.
Okay, consider it, but we need more research.
And the Society of Vascular Surgery, SVS, also in 2016, offered recommendations or suggestions favoring the use of HbO2 for diabetic foot ulcers that are failing to improve despite good standard medical and surgical care. So as you can see, it's a bit of a mixed bag, ranging from cautious suggestion to recommending against routine use to recommending it for non-healing ulcers.
Definitely a range of perspectives, likely reflecting those nuances and debates in the underlying evidence we've been discussing. Now, you mentioned earlier that the Undersea and Hyperbaric Medical Society, the UHMS, developed its own clinical practice guideline using a specific, rigorous methodology called GRADE.
Yes, that's right. The UHMS, being the main professional society focused on hyperbaric medicine, put significant effort into developing a guideline specifically for this indication. They used the GRADE methodology, grading of recommendations, assessment, development, and evaluation, which is a very systematic and transparent process for evaluating the quality of evidence and formulating recommendations.
And how did they approach categorizing patients?
They made a conscious effort to try and stratify patients, not just by the severity of the ulcer using the Wagner grade, which most guidelines rely on, but also considering the acuity or chronicity, how long the ulcer had been present. They recognize, for example, that a newly developed severe ulcer might respond differently than a chronic, non-healing one of the same Wagner grade. They created tables trying to parse the evidence based on these factors.
That sounds like a more nuanced approach. So what were the key recommendations that came out of that UHMS guideline process?
They essentially made 3 key recommendations based on their grade evidence review. First, for less severe ulcers specifically, Wagner grade 2 or lower DFUs that have been present for more than 30 days, they recommended against using HbO2. They rated the evidence supporting its use in this group as very low.
Okay, so not for the chronic, the less severe ones. What about the more severe ulcers?
For the more severe ulcers, Wagner grade 3 or higher DFUs that have also been present for more than 30 days and haven't shown significant improvement with good standard care, they suggested adding HbO2 to the treatment plan. They based this on moderate-level evidence indicating a potential benefit in terms of reducing major amputations and improving the chances of complete healing.
Okay, a suggestion for using it in chronic, severe, non-healing ulcers. And the third recommendation?
The third recommendation dealt with the acute setting. For Wagner grade 3 or higher DFUs that have recently undergone surgical debridement to treat infection, they also suggested adding acute postoperative HbO2 as part of the standard care package. Again, this was based on moderate-level evidence suggesting a potential reduction in the risk of subsequent major amputation.
So the UHMS guidelines offer a more specific, stratified approach, trying to target HbO2 based on ulcer severity, chronicity, and the recent surgical context, aiming it where the moderate evidence suggests it's most likely to help.
Exactly. It's an attempt to move beyond a one-size-fits-all approach and provide more tailored guidance based on the available, albeit imperfect, evidence.
That seems like a helpful framework. To really bring all this together and make it concrete, maybe we could walk through a few hypothetical patient cases, see how these recommendations and the evidence might play out in different real-world clinical situations.
Absolutely. Case examples are a great way to illustrate the decision-making process. Let's take case 1. Imagine a patient presents with rapidly progressing wet gangrene in their foot. They have known severe peripheral artery disease, very poor circulation.
Okay, a critical situation.
Right. In this scenario, the absolute first priority, guided by basic limb salvage principles, is vascular assessment and intervention. You need to maximize blood flow to the foot, if at all possible, perhaps with angioplasty or bypass. Only after addressing the vascular supply might you consider HbO2.
How would HbO2 help then?
It could potentially help demarcate the line between viable and non-viable tissue, making surgical debridement more precise. And then potentially, using postoperative HbO2 might support healing in the remaining tissue, assuming adequate blood flow has been restored. But the vascular status is paramount. You have to address that first.
Makes perfect sense. Fix the plumbing first. Okay, case 2. What about a patient with a chronic non-healing heel ulcer, maybe with some gangrene and bone infection, osteomyelitis, but they're non-ambulatory, perhaps bedbound or chairbound?
This is a really important scenario. This patient might technically meet criteria for HbO2 based on the ulcer severity, Wagner grade 4 or 5, and chronicity. However, the inability to effectively offload pressure from that heel wound is a massive barrier to healing.
So even if HbO2 improves oxygen, the pressure damage continues.
Exactly. HbO2 alone is highly unlikely to overcome the constant pressure trauma. In this situation, focusing on finding the best possible offloading strategy, which can be extremely difficult for heel ulcers in non-ambulatory patients, or perhaps even considering a primary amputation for quality of life and palliation, might be more clinically appropriate than pursuing weeks of HbO2. HbO2 can't compensate for inadequate fundamental wound care, and offloading is fundamental.
Right. HbO2 isn't magic. It needs the basics in place. Okay, case 3. How about a patient who develops a single gangrenous toe, but their overall foot circulation, their vascular studies are actually pretty good?
Okay, so the presence of gangrene makes it severe ulcer, technically Wagner grade 4. But given the adequate blood supply to the rest of the foot, is HbO2 necessary here? The UHMS guidelines, remember, suggested against routine use for lower grades, and while this is grade 4, the lack of underlying ischemia is key.
So maybe surgery alone is sufficient.
Very possibly. In this specific hypothetical case, let's say the patient had the toe surgically removed, a digital amputation, and the surgical site healed perfectly well without any complications and without needing HbO2. It highlights that ulcer severity classification alone doesn't automatically mean HbO2 is needed. The underlying vascular status and overall clinical picture are critical.
Good point. Not all severe-looking ulcers need the full advanced therapy arsenal if the blood flow is good. What about case 4? A situation where the diagnosis itself might be wrong initially.
An excellent point. Imagine a patient referred for HbO2 with a diagnosis of Wagner grade 3 equivalent ulcers on their lower legs. They failed some initial treatments.
Okay, sounds like they might fit the criteria.
On the surface, maybe. But upon more thorough evaluation, perhaps by a wound specialist, it's determined that these aren't diabetic foot ulcers at all. They're actually venous stasis ulcers, caused by faulty veins in the legs.
Ah, a completely different underlying problem?
Completely different pathophysiology, requiring a different treatment. HbO2 is generally not indicated or proven effective for venous ulcers. The standard treatment is compression therapy. In this case, the patient's ulcers healed well once appropriate compression was applied. It underscores how absolutely crucial an accurate diagnosis is before jumping to advanced therapies like HbO2. Get the diagnosis right first.
Absolutely critical. Don't treat the wrong condition. Okay, case 5. What about a patient with a deep infection, like a deep space abscess in the foot? Maybe they also have neuropathy and Charcot changes in their foot structure.
Okay, this is a common and challenging scenario. Let's say this patient has good blood flow confirmed by vascular studies, but because of the deep infection and inflammation, they show signs of significant local tissue hypoxia right around the infection site.
So good main pipes, but local tissue is struggling for oxygen.
Exactly. Given the deep infection requires urgent surgical drainage and antibiotics, this is a scenario where adjunctive HbO2 is often considered and likely beneficial. Using it alongside the surgery and antibiotics, typically the hospital setting, can help combat that local hypoxia, potentially enhance antibiotic effectiveness, and support healing after the infection is cleared. This aligns well with that UHMS recommendation for considering acute postoperative HbO2 after surgical debridement for infection in severe ulcers.
Makes sense. Supporting the tissue's fight against infection. Finally, case 6. A patient with osteomyelitis, bone infection in a toe, maybe with a small overlying ulcer, but again, their vascular studies are normal, good blood flow.
Right. So we've confirmed bone infection requiring treatment, likely surgical removal of the infected bone toe, but no significant ischemia. The decision about using HbO2 here and whether to use it before or after the planned surgery gets pretty nuanced.
Way nuanced.
Because there's no clear evidence of tissue hypoxia stemming from poor circulation, using HbO2 before the surgery is probably not indicated. The primary problem is infection, needing surgical removal. Postoperatively, well, The UHMS guidelines might suggest considering it based on the ulcer potentially being Wagner grade 3 if bone is exposed, but the patient's excellent vascular status suggests a lack of oxygen probably isn't going to be the main barrier to healing the surgical site.
So it becomes a judgment call.
It really does. It highlights the importance of clinical judgment, considering all the factors: infection, perfusion, patient goals, not just ticking a box based on Wagner grade. And it also underscores where we need more research guiding decisions in these more complex, less clear-cut situations where ischemia isn't the dominant problem.
These cases really drive home the complexity, don't they? Treating DFUs is definitely not simple, and deciding on HbO2 requires a very careful, individualized approach. Looking ahead then, based on all this, what are the key areas where future research really needs to focus in this field? What are the next big questions?
I think future research really needs to shift its focus. We need to move beyond just looking at ulcer depth, the Wagner grade, as the primary driver for HbO2 decisions.
Yeah.
Instead, the focus should be much more on directly assessing tissue oxygenation. Is there actual hypoxia present? And also considering the acuity of the ulcer. Is it a rapidly worsening acute problem or a stable chronic wound?
So physiology over just anatomy.
In essence, yes. These factors, hypoxia and acuity, likely play a much more significant role in determining who will truly benefit from adding HbO2. The ongoing Dutch clinical trial, for example, which is specifically investigating HbO2 for ischemic DFUs defined by precise oxygen pressure measurements, is a really important step in that direction. We need more studies targeting these specific physiologically defined subgroups.
That sounds like a much more targeted approach for future studies. So wrapping this up, it seems clear that while the evidence supporting HbO2 for diabetic foot ulcers is perhaps more substantial than for some other conditions where it's used, it's definitely not a magic bullet or a universal remedy.
Exactly. That's a perfect summary. The best outcomes, the highest likelihood of success, really occur when HbO2 is used thoughtfully as one component within a comprehensive, multidisciplinary limb salvage program. A program that meticulously addresses all those standard care elements we talked about, ensuring good blood flow, effective offloading, aggressive infection control, tight glycemic management, thorough debridement, optimal local wound care. HbO2 works best when it's integrated into that whole package.
And careful patient selection based not just on guidelines, but on the best available evidence applied with sound clinical judgment seems absolutely paramount. The decision shouldn't just be driven by whether insurance might cover it, but by a thorough assessment of the individual patient, their specific ulcer characteristics, and the potential for real benefit.
Precisely. It has to be a clinical decision, first and foremost. Which brings us, I think, to our final provocative thought for you, the listener, today. Given this landscape, we've explored the varying levels of evidence, the ongoing debates, the different guideline recommendations. How should individual patients and their healthcare providers best navigate this complex decision? The decision of whether or not to add adjunctive hyperbaric oxygen therapy for a specific diabetic foot ulcer.
Yeah, what are the most critical questions they should be asking themselves and each other as they weigh this treatment option?
We'd encourage you to think about all the factors we've discussed: the underlying blood flow, the presence and severity of infection, the depth and duration of the ulcer, the crucial ability to effectively offload pressure, and the evidence for tissue hypoxia. Considering all these elements, perhaps using the UHMS recommendations as a starting point for a deeper conversation can hopefully help guide a more informed, personalized, and ultimately effective approach to tackling this very challenging clinical problem.